oh, you're pre-diabetic. Let's do something about it. Because that pre-diabetic is really that warning sign that says,
yeah,
we have a chance of reversing this at this stage.
All right. Welcome back to the Alternative Flight Plan. This is a podcast about navigating complex health challenges by exploring the spaces where conventional medicine and alternative medicine approaches intersect, and sometimes where they don't. Today's guest is Dr. Jason FauntLeRoy. Jason is a naturopathic physician specializing in endocrinology and diabetes. He's based in Seattle and is the founder of FauntLeRoy Naturopathic Medicine. Jason has been living with type 1 diabetes himself for 15 years, which gives him a unique firsthand perspective on managing chronic disease. He completed his undergrad in exercise science at the University of Montana before earning a doctorate in naturopathic medicine from Bastyr. He completed a 2-year residency in Seattle, and he's also been recognized by Seattle Met Magazine as a Seattle top doc for 3 consecutive years from 2023 to 2025. So without further ado, let's taxi our aircraft to the catapult and get airborne. Jason, welcome to the Alternative Flight Plan.
Love it. Thank you so much for having me, Dr. Barnes.
Jason and I have had this conversation a couple times. He and I started medical school together in September of 2016, which is almost exactly 10 years ago now. We sat down in the auditorium together, not realizing that the next 5 years, we'd be going through this journey together. He took a brief pause, after his first year, and then we ended up graduating together in 2021. So I've watched him grow as a doctor, as he's done the same for me. And then we ended up doing our residency together. So we did 2 years in the Ballard neighborhood of Seattle, doing a lot of family medicine, primary care, working with populations that included the very wealthy, from the very wealthy down to the folks that were on Apple Care and Medicare, Medicaid. So we've done a lot of our time together in parallel. Since then, we've actually taken very different pathways through navigating medicine. So, Jason, why don't you start a little bit about where you are and what your specialties are, and why would we want to have you on the Alternative Flight Plan?
Great. Yeah. Thanks for that. I cannot believe it has been that long that we've been on this journey together. It's phenomenal. And you're right, we have done it in the same way and had a unique path forward that has been a little bit different than each other. I found out I was diabetic before going to med school. So then through school, every time somebody said diabetes, of course I paid attention because it directly applied how I treated myself, right? And so I got the experts' education on diabetes, and it just was something that I absolutely loved, helping other people find options for. There's so many questions out there. There are a lot of people that get misinformation or just a new diagnosis and need education on it. And so it's my privilege to be able to be a part of that journey for folks, to help them understand what the right treatment options are, or even, if treatments are needed, right? People have questions about natural options all the time. And so it has been a lot of fun to dive in with people into endocrinology or diabetes specifically to help them get to where they want to go in their health journey.
Yeah, and so you don't just have diabetes; you have type 1, which makes it a little bit of a different animal, if you will. How does talk to the audience a little bit about the difference between type 1 and type 2? And there's a little bit of talk out there today about a type 3 diabetes. So talk a little bit about the different manifestations and where they might overlap or go in different directions as far as treatment.
Awesome question. This is common. Often even people who are dentists get confused on which one's type 2, which one's type 1. Type 1, like I have, is for some reason, my immune system killed off the cells that produce insulin, the beta cells. So I produce no insulin, and I need to be injected with insulin on a daily basis, where it is actually a terminal disease without that, missing hormone that's needed for handling the sugars that we eat and the fuel that we consume. Type 2 is a little bit different. This is where we've kind of traditionally called it insulin resistance. And you think about it having a lot of sugar around for a long period of time, not a lot of exercise to burn that sugar. So we just have so much of it that your body can't handle it. And it starts producing more and more insulin and can't keep up with that sugar. So eventually you end up with this resistance, or this picture where the blood sugars are high, which is exactly the same consequence of not having insulin. Your blood sugars are high. So they kind of both have that same cause. And then that high blood sugar increases inflammation, damages blood vessels, including the heart, starts causing things like blindness, all of the complications that kind of go along with it. So that's the basic difference between the two. And then just to make things slightly more confusing, we start saying there's a 1.5 or a 3 or, some sort of blend between these. And that's where it gets really confusing, but I don't necessarily have to go into too much detail. There's just additional additive factors that can be creating these complications with blood sugars. So they're just kind of extensions off of the other two.
I think one of the most frustrating things I have with patients, you do a lot of education like I do, is the lack of understanding around what the labs tell us and what should be done based on that. For example, I have had a patient in the past who has type 2 diabetes, something that they've developed over time. And they're under the care of a primary, a medical doctor who is endeavoring to keep their blood sugars somewhere around 6 or 6.5. And then this patient also comes with neuropathy, which is one of the complications of diabetes. And they want counterstrain or they want acupuncture for the neuropathy, but there's not a conversation around the blood sugars that are between 6 and 6.5. How do you approach that in the work that you do with your patients?
It's tricky, right? We're trying to meet the patient where they are and educate at the same time. So we do know that high blood sugars can impact and damage the nerves, which then cause the numbness, the neuropathy that's happening, right? So traditionally we think, oh, you're well controlled if you're at an A1C of a 6, right? So that's a good place for a diabetic to aim for so that they can get as close to normal as possible. But the reality is that it is still abnormal blood sugars. They're still elevated. They still are causing damage. And so this individual might be predisposed, right? They may have other inflammatory conditions that are increasing their risk for neuropathy, right? And so you have to take it by an individual basis and really understand all the risk factors, because diabetes is one piece to the puzzle of who a person is and what they're experiencing. And it does make every other condition that you have a little bit more complicated, right? Like it is damage, it
Yeah.
is inflammation, it is not it's on its island all by itself. It's part of the whole picture.
Yeah. Well, I think one of my frustrations is that if you have other inflammatory things going on and you're only targeting a 6.5, that's not good enough. And we need to open the conversation. And it's educating, like, all right, 6.5 was good when you were at 13.
Right, right, right.
13 is a really high A1C. 6.5 was a good target when you were at 13, but now that you're at 6.5 and you still have symptoms that are inflammatory in nature, we need to target something lower.
Yeah, absolutely. And also recognizing that if you were 14, you might have had some damage when you were at 14. And even though we're at 6, we might not necessarily be able to reverse all of the nerve damage that happened. There are some products out there that at least have some promise, right? But that's tricky and we have to be realistic. That's very different than a story of someone who was 7 and got down to 6.5, right? We're not as worried about long-term damage, but if they're still having symptoms, we have to address it. So it's very individualized. It's very specific to the case in front of you.
I do have patients who come to me and they have all this damage that has already occurred. It could be they've had a stroke and now they want a TBI protocol to help get their cognitive ability. They've had a stroke and they want counterstrain to bring. But the thing is that once the damage happens, there's no guarantee that a natural remedy or a body work or a red light therapy or acupuncture is going to be able to bring that back. And so it's part of the conversation for people who haven't sustained that kind of damage, is to not let that happen in the first place.
That is one of the core tenets of naturopathic medicine, is the prevention side of it, right? That would, in an ideal world, that's what we'd be aiming for. We would be catching people early by doing some sort of screening. You go to your annual exam and you look at an A1C and see, oh, you're pre-diabetic. Let's do something about it. Because that pre-diabetic is really that warning sign that says,
Yeah.
we have a chance of reversing this at this stage, before it becomes something that kind of snowballs out of control. And when it happens, sometimes it can happen really quick. People go from an A1C that's fairly normal to a really bad one within 6 months, right? And that can be some damage that, like you said, is irreversible. So the goal is to prevent it if at all possible. And, just awareness is, I think, that first step. Like, am I actually getting my A1C looked at? Do I have a doctor? Do I have someone who I can trust that's running these labs just once in a while? What's my family history look like? Am I predisposed as it is with my genetics? Lots of moving parts.
Yeah. I think it's one of the reasons I do like the companies that do these bulk labs. I can't think of anything right off the top of my head, but I do have patients that come to me and they've got 16, like that's not an exaggeration, like 16 pages of results. And they don't really have anybody who can look at, zoom out and look at the big picture. But if you have somebody who's 40 or 45 and doing one of these tests, I'm like, this is actually kind of a cool thing because you're establishing a baseline for things like A1C and thyroid, because I don't think thyroid gets looked at enough either. But if we have a trend starting early enough, then we can catch those things early. It's really unfortunate when we have people who are seeing medical doctors that say there's nothing that we can do for you. We're going to put you on insulin for the rest of life. And now the person's like,
Mhm.
oh, well, maybe I'd like to look at some natural therapies. And like, I don't know how well that's going to work. There are certainly things that we can do to keep it from getting worse. But as far as reversing damage, that's a tough conversation to have with folks.
It is. It absolutely is. So prevention's the key. My stepdad actually just called me the other day and said, I found out through, he donates blood. He's a universal blood donor, and found out he has a slightly elevated A1C. He's in that pre-diabetic range. And so that's what I told him. He was all worried about it. I was like, no, this is great. Now we know, now we can do something about it. Right. So that's the ideal scenario, is to find someone early, do the education so that we can connect and really find the plan that fits their lifestyle too, right? Not everybody is going to be the same just based on what their career looks like or what age. Like, some people end up with high A1Cs after injuries, or where something happened where they're no longer able to be mobile, and it goes hand in hand with your other physicians. And that's the piece I'd like to make, is I really want to collaborate with the other folks who are doing the other parts, right? So that we can all be a part of the team, and I can work with you or the body worker, whoever that is, that's also part of the process.
I think one of the more challenging cases, or the type of challenging case that I see, are because my population is older women in essentially what is a retirement community, and younger people who are under the or in as part of the lower socioeconomic bar. So stress. So they might eat really well. They might actually be moving quite a bit. Younger people are moving quite a bit. Or older women that are hitting menopause and they eat a really good diet and somehow their A1C starts to get elevated and they're like, what's happening? Why is that? What are your thoughts on that?
This is perfect. This is a great question. Really, thank you for asking it. So many people are doing so much right. Their diet, exercise, they've done it right their whole life. And all of a sudden they see this creeping up. And it is often involved with cortisol. And what is cortisol? It's a stress hormone that is activated oftentimes when you're stressed, sitting in front of a computer. You're dealing with all the busy emails like I'm doing all the time, and it's fight or flight. It's getting you ready to run from a danger. So it's mobilizing blood sugars from storage. So we store all of it in the liver and a little bit in our muscles, and that cortisol actually gets it into the bloodstream. So it's ready. So if we do actually have to run from a tiger, we have the energy to do that. Then you often don't go running, right? Because you're sitting at a desk for hours, and that sugar just stays around in the system, and it's creating this kind of chronic elevation due to just kind of this chronic stress of being an adult and trying to figure out our life, right? And that sneaks up on people. And so the stress picture is absolutely a huge contributor to many people, who, especially those people who think they're doing everything right, and they are doing so much right. And you can't necessarily control stress that's external. So it's a big part of the picture.
Yeah. It is. I've had a couple of patients I've had to work with where it's taken a number of visits to really dig into the history, the family genetic history, the family social history. Like we pass not just genes, but we pass on belief patterns, eating patterns, exercise patterns. Like all those things are passed down in the family. And then what kind of endogenous stress is going on? Like people who have internalized belief patterns that are negative have a lot of insidious stress that you can't necessarily see from the outside. But working through that can be a little bit of a challenge. Okay, we've worked out all the obvious, the horses, as we
Mhm.
say. Now, where are the zebras that we need to look at? So you have an undergrad in exercise science. So you have an
Yes.
athletic background. How does that fit into what you do as far as diabetes and prevention and all the things?
Surprisingly, I use it a lot. People are wanting to know what's the best type of exercise. How long should I go for? So it bleeds into it a little bit. And realistically, it's pretty cool. The data is pretty strong in this, is that lifestyle interventions such as diet and exercise is like 53% effective compared to half that for your most of your major medications. So, and then it's longer lasting when you actually get some long lasting lifestyle change, right? So making dietary or exercise adjustments in somebody's lifestyle can be doubly effective as opposed to medications, according to the research, right? Every individual is different, but it shows that if we could get there and we can make and carve out the time and space in our lives and create the changes in our diet, it can be a really hugely impactful piece that can reverse diabetes or prediabetes in most cases, right? So this exercise part to it comes in handy all the time because people do. They want to know, should I be lifting weights? How does that impact my blood sugars? Or does it need to be cardio, right? Like there's so many different ways of doing this that I end up answering a lot of like almost personal training questions on a regular basis, which is kind of fun.
Well, no doubt. And when I ask people if they're exercising, I always say, "How are you moving?" Because I think a lot of people, especially older women, grew up in an era where women didn't as necessarily exercise, and
Absolutely.
saying like, and humanity hasn't exercised. If you're not looking at the video, I'm using air quotes. Like that's not how humans evolved to move. We evolved to walk and run and lift heavy things and do manual labor. And I think that's a completely valid way to look at movement. Although if you're in an urban environment, like, you're working with a patient in Seattle, that's going to look a lot different than somebody like I have a number of patients who are farmers and they do manual labor for a living. Like I'm not going to tell somebody to go lift weights if they're already doing manual labor on a farm. But I
Right.
think the
Right.
point is to get your body moving, especially postprandial, meaning right after you eat, do a little bit of movement that fits for your age, your body type, and your lifestyle, and in a way that it's palatable. So you're not trying to fit a program that doesn't work onto somebody that it won't end up doing it in the first place.
Mhm. That's huge. What you just said is gold. Doing some sort of movement after the largest meal of the day is as effective as adding a medication onto someone's diabetes plan. And if they can do that regularly, there you go. You may not need meds, right? Like that can change a person's total parameter, and especially if within that 30-minute window is really where the science shows. Yeah, that's when the blood sugar is spiking. So let's use that blood sugar. Let's use it as fuel and prevent it from causing the damage. So gold. I love what you said.
Um, I'm gonna tell on myself a little bit. I do a little bit of biohacking, and I know that if I'm gonna force myself to get out and move, what all I have to do is eat a little sugar because now
Hmm.
I'm like, well, if I don't eat it, it's gonna jack up my sugar, so I'm gonna feel guilty. So, anyway, yeah, that 30-minute window is really important. One of the conversations I have with a lot of patients is about insulin resistance, how we find it, how like what's the lab work for that? What does it mean, and how can we reverse it? And it's not one of the conversations I think that I feel like medical doctors are having with patients. They're supporting them with medications and maybe a little bit of diet and lifestyle. We don't know. I think it depends. But how do you talk about insulin resistance with patients and perhaps work with them to reverse it so they're more sensitive to the insulin that they do have in their body?
Start with saying that the insulin resistance, there is even actually a little bit of a conversation around, is that the right term to use? I don't know if you've ever listened to Dr. Jason Fung. There's some different
Oh
ideas that
yeah.
there's maybe a little less of insulin resistance. That makes me think of almost like you've taken a drug and now you're becoming more resistant to it over time, and it requires more and more and more of that drug to be used. And that's kind of what the idea was behind insulin resistance. The other ideas are more along the line of glucose overload. You have so much glucose in your system, only so much can fit into the cell or let's just use the analogy for a suitcase. And once the suitcase is full, it doesn't matter how much insulin you have. That insulin's a signal to put more glucose into the cell. If it's full, where does it go? It's there's nowhere to go. And so that's another kind of separate idea that's kind of hand in hand. And the truth is we don't know exactly the full pathophysiology of exactly what's happening. It's so complex. It's quite fascinating. But how would we talk to people about it? It's too much sugar is the simple way, right? Like we start there and we work our way up because some people are really, really knowledgeable. They know what a carbohydrate is. They know what a diet plan can look like. And other people don't know what carbs are. So sometimes you have to meet that person where they are. But ideally, it's to start educating step by step so that they can understand these are the labs we use to monitor what is an A1C, right? Wait, do you need a continuous glucose monitor? It's probably one of my favorite tools that we use.
Yeah.
Is those monitors that go on and they give you real-time data on what your blood sugars are doing. So you can see, oh gosh, I ate that. I went and had birthday cake, or I had all that food on Easter Sunday, and look at what it did to my blood sugars all night long while I slept. And that awareness piece, I think, is one of the best tools that we have right now.
Okay. Well, I think the takeaways from the first part of our conversation together is that there is room for both the preventative piece and then the disease management piece. And I do like working like in concert with a host of a medical team for somebody to make sure that because I know that medical doctors don't have time with the system that we have to give a lot of diet and lifestyle direction. And I don't know that I'd want nutrition advice from a medical doctor anyway. That's not really what they do. So diet and lifestyle are effective. And if there's somebody that's at a level of disease where they need that intervention, somebody who has an A1C of 10 or 13 or higher, then of course we're going to use the medications to help get them back into a reasonable place where diet and lifestyle is going to be really, really effective. All right. Thanks, Jason, for the first segment in our conversation together. He and I have extended our talk into another segment. So if you'd like to listen to the next part of our conversation, please click on the link below.